Hello, everyone, and welcome to this multiple sclerosis continuing medical education series. My name's Lucas Kipp, and I'm a clinical assistant professor and MS specialist here at the Stanford MS Clinic in Palo Alto. Over the next 5 lectures, we'll be exploring key concepts in the diagnosis and treatment of multiple sclerosis and give you the skills to recognize MS early in the disease course, initiate high-efficacy disease-modifying therapy promptly, and improve long-term outcomes. In today's lecture, we're going to be focusing on the immunopathogenesis of MS, the epidemiology of the disease so you can recognize those at greatest risk walking into your office, including the role of the gut microbiome, which you may have been introduced to in our short animated video that accompanies this lecture series. So to start, MS is an autoimmune disease, which very simply means that the body's own immune system is targeting and attacking its own host tissue. So if the immune system attacks the joints, for example, we call it rheumatoid arthritis. If the immune system attacks the small intestine, we call it Crohn's disease or ulcerative colitis. But if the immune system attacks the central nervous system, so the brain, the spinal cord, or the optic nerve, we call it multiple sclerosis. And what's exciting about the field of immunology is that the discovery in any one of these particular disease states can often pay dividends in others. For example, a number of our MS drugs are shared with our colleagues in rheumatology, gastroenterology, oncology, and vice versa. And although we've learned a great deal about MS since Jean-Martin Charcot's first lectures on sclerose en plaques, all the way back in 1868, the overall etiology and the complete immunopathogenesis still remains elusive. Ultimately, there's this complex interplay of genetic predisposition, which we're going to talk about today, and environmental factors that ultimately results in immune system dysregulation, leading to the generation of these autoreactive immune cells that invade and attack our central nervous system. Now, the relapses or the clinical experience of MS is thought to be caused by the development of these aggregates of inflammatory cells in eloquent areas of the CNS. And it's these inflamed areas which are also associated with the breakdown of the blood-brain barrier. These appear as gadolinium-enhancing lesions on MRI around the time that they develop. So that blood-brain barrier breaks down and that contrast leaks out and kind of stains that area that's actively inflamed. But then downstream over weeks to months, that inflammation leads to the loss of oligodendrocytes. So those are the myelin-producing cells in the central nervous system. So you get breakdown of their associated myelin sheaths. So the electrical conduction down those axons doesn't work very well and produces the symptoms that patients experience. But you also get axonal loss in all of these scars. And that ultimately appears as a permanent demyelinating plaque, which is the hallmark pathologic marker of multiple sclerosis in both pathology tissue and what we see on MRI. So who does this affect? Well, we know that MS is a global disease affecting about 2.8 million people worldwide. And this equates to about 1 in 3,000 people in the world that are living with MS, with certain countries that are more disproportionately affected, which you can see on the map here. Worldwide, this translates into a new diagnosis about every 5 minutes around the world. So this is something you're going to see in your clinical practice, whether you're primary care, internal medicine, neurologist, etc. Now, the United States is disproportionately affected. And a recent prevalence study published in 2019 reports that there's almost 1 million Americans living with this disease, or about 1 in 300 people. This is actually double our previous estimates from back in the 1970s. And again, it really highlights the importance of recognizing this condition in practice. This rising incidence is also present in all of the 6 World Health Organization regions, places like Europe, the Americas, Eastern Mediterranean, Southeast Asia, Africa, the Western Pacific. And these numbers are going up probably for a number of reasons. One, we're better at diagnosing MS. We've got improved treatments and support, so people are living longer, better lives with MS. We've also got a better ability to count the number of people with MS around the world, and our global population is going up. If there's one positive effect about these increasing numbers, organizations like the National MS Society have successfully leveraged these prevalence estimates to increase investment in MS research with Congress. And as a clinical researcher as well, that's exciting for me so that we can really push the field to find the cause and cure of this disease. MS also affects people in the prime of their lives. This is typically between the ages of 20 and 40 years. It's the leading cause of non-traumatic disability in this age group and the #1 cause of wheelchair use. Now, those individuals in this age group who are going to be presenting to your office over this next decade are those from the millennial generation, which is really defined as individuals born between the early 1980s and the mid-1990s. Looking at this graph of age at MS onset, just the age of someone coming into your clinic can give you a sense of, what's the likelihood that this neurologic symptom that they're coming in for is the first sign of multiple sclerosis. And a good rule of thumb is that if someone's kind of under the age of 15 or over the age of 50, it's pretty unlikely that that's going to be multiple sclerosis. But it can happen on the tail ends in each of these really young or much older age groups. But the bulk is really going to be in the 20 to 40s, like we discussed. So what are the risk factors? What do we know about who's at risk for this in terms of genetic risks? Well, we know that there must be a genetic component because the ratio of women to men is much higher, about 3 to 4 to 1, depending on what study you look at. We also know that if you've got a first-degree relative, if you've got a parent or a sibling that has MS, your lifetime risk is about 3 to 5%, which is 15 to 25% higher than the general population, 15 to 25 times higher, than the general population. And so that can't be the whole story though, because if you've even got an identical twin who shares 100% of your DNA, your lifetime risk is only about 30%. So genetics can't be everything. The other thing I wanted to mention is that MS occurs in most ethnic groups, even though traditionally we talk about it being increased in Caucasians and those of Northern European ancestry. But that susceptibility rate actually varies a lot between different groups. We've got recent findings that shows that actually African American women have much higher rates than Caucasian Americans. So there's other factors that are playing a role here as well. In terms of what genes have actually been implicated, there's an international MS genetics consortium that was established back in 2003. It involves researchers from over 30 institutions, 18 different countries who have already analyzed over 100,000 samples. And they've identified over 233 variants that are associated with MS risk. And they explain nearly 50% of that estimated heritability of MS. Now, most of those variants that we see are associated with immune cells or immune cell function. And the strongest association we have is if you've got a particular HLA-DBR1-1501. This is more common in European ancestry, and it increases the risk of developing MS 3 to 4 times. But really, the key take home from this is that MS is not a single gene disease. It can be related partially to multiple genetic factors, but it's not the whole story. And we actually don't use genetic testing in clinical practice because it doesn't change the way that we diagnose MS or treat or prognosticate in MS at this point, even in 2022. So what else is going on? Well, we have a lot of evidence that environmental factors play a big role in the development of this disease. And we're going to talk about each of these in turn. So the first is geography. And I already showed you this map, but we have several studies that show the effect of latitude on MS prevalence. And generally, the closer one lives and grows up to the equator, the lower the risk, versus the further you get away from the equator, the higher latitudes towards the poles, the greater the risk of developing MS. This is also seen within countries. So for example, the United States, we see this difference in risk begins to emerge around the 37th, 40th parallel, which is right about where we are here in Palo Alto, a little bit further south. Well, in Australia, people living in Tasmania, which is all the way down here, have a double the risk as people that live up in the northern state of Queensland. So we know that there's this latitude effect. But why? Why does this latitude effect exist? Well, we think it's related to the amount of sunlight that people get that live at these latitudes and the ability to produce enough vitamin D from that sunlight. So areas where there are reduced UVB light exposure is strikingly similar to maps of MS prevalence, both globally and within countries like the US and Australia. And the reason for this is that UVB light can only reach the ground and thus someone's skin where it's converted into vitamin D if the sun is sufficiently high in the sky to penetrate all those layers of the atmosphere. And as latitude increases, kind of the angle that the sun is at can't actually penetrate all of the layers. So beyond the 40th parallel, which includes vast proportions of North America, Europe, the former Soviet Union, as well as some countries in the Southern Hemisphere, the amount of UV light is insufficient to produce enough vitamin D for the body for most of the year. So how might vitamin D affect the immune system and contribute to MS risk? So for immune health, people need at least a serum level in their blood of vitamin D of about 30 to 60 nanograms per milliliter, and then permanently maintain that level. And to do this, people need to have about 2,000 to 4,000 units of vitamin D daily from all of their sources, which is only observed in people that live in tropical countries or outdoor workers during the summer. And even if you have a well-balanced diet or a fortified diet, because a number of our foods in North America in particular are fortified with vitamin D for this reason, they only provide about 3,000 international units per day. We also don't reliably store vitamin D. And generally it disappears after about 6 to 8 weeks after sun exposure or from taking it orally. Now, the way that vitamin D is metabolized is that it happens first in the skin. Then it goes under 2 hydroxylation steps, first in the liver and the kidneys, to become its active form, which is called calcitriol. But how does this actually, change our immune response? Well, that calcitriol can then go into the cytoplasm of cells, immune cells, nervous tissue cells, and it can form a heterodimer, which can then go to the nucleus and actually turn on or turn off gene transcription by interacting with what's called the vitamin D response element. So in the human genome, about 5 to 10% of our genome actually has a vitamin D response element that can be influenced by the vitamin D levels in our blood at any given time. And interestingly, one of the genes that has this element on it is the HLA-DRB1 1501 allele that we know has a significant MS risk. So there's a really eloquent epidemiologic, but also immunologic way in which vitamin D can alter MS risk by helping determine what types of immune cells are turned on and turned off by gene regulation. We know that vitamin D deficiency increases MS risk. We know that if we supplement vitamin D before people develop MS and bring their vitamin D levels up, it reduces the likelihood they're going to develop MS in the future. We also know that once people already have MS, if we treat them with vitamin D and bring those levels up, it reduces the likelihood of MS relapses. Some modeling suggests up to 50 to 70% relapse reduction, but also in the number of new lesions on their MRI as well. What about obesity? This is another risk factor that increases the risk of developing MS by 2 times. This is most prominent in adolescents, in particular adolescent females. Much like vitamin D, being obese when you already have MS increases your risk of relapse as well as MRI activity. And we think the way that occurs is by inducing a more pro-inflammatory state with pro-inflammatory cytokines called adipokines. We also know that vitamin D is a fat-soluble vitamin. And so if you are overweight and you've got more adipose tissue, that vitamin D gets sequestered in fat cells, and it's not bioavailable to circulate in the blood and ultimately regulates gene activity. There's also been a lot of interest in whether viruses can serve as a trigger or risk factor for MS. And for many years, Epstein-Barr virus has been implicated. And only just recently have we found the most strong evidence implicating it as a potential trigger in MS. So Epstein-Barr virus is a human herpes virus. And it's consistently been shown to be associated with increasing MS risk in both adults and in pediatric MS, and in multiple different races and ethnicities globally. Now, interestingly, about 100% of people that are diagnosed with MS, if we do a blood test and look for an antibody that shows that they've been exposed to MS in the past, about 100% of people with MS have had prior exposure to EBV. Now, most Epstein-Barr virus infections occur in childhood, and they're asymptomatic. You don't even know that you've picked it up. But if you're clinically symptomatic, and this usually happens in adolescence or early adulthood, if you actually feel the symptoms of what are called infectious mononucleosis, your risk is increased substantially. So there may be a key time period in adolescence of this virus that is a particular risk factor in terms of a trigger. We also know that the more antibody to the virus that you have, you're also at higher risk. And if you have some of those MS genetic variants, or you're obese, combined with Epstein-Barr virus history, those risks are even amplified even more. Now, just recently, we have 2 very, very strong papers published in both Science and Nature, 2 of the most well-respected academic journals in the world, that have further strengthened this connection. So the first was a paper out of Harvard in Science, where they looked at data from 10 million young adults who are on active US military duty and monitored them for over a 20-year period. And they determined that the MS risk is increased 32 times following an Epstein-Barr virus infection. Now, despite this strong connection, we still didn't know why or how Epstein-Barr virus could trigger MS until a few weeks later when our group here at Stanford published this article in Nature. And what we found is that people with MS have antibodies to an Epstein-Barr virus protein that cross-reacts with a protein expressed in the cells of the myelin sheath in the brain and spinal cord, something called glial cam. So what this means is that we have found proof of what's called molecular mimicry. So when someone's immune system gets exposed to that Epstein-Barr virus, it does its job and it creates immune cells to prevent that virus from causing, infection and symptoms and getting sick. But by doing that, because there is a protein on that Epstein-Barr virus that looks very similar to a protein on the myelin sheath, your immune system creates immune cells that attack both. And even once the Epstein-Barr virus goes away, you are still left with those immune cells that are going to continually try to attack that myelin sheath in the central nervous system. And this is really exciting. This is the hottest thing in the MS field in quite some time, because it also opens up more treatment options. And so already in development are potential vaccines for the Epstein-Barr virus to prevent MS in the first place, or treatments that can potentially target the pathway that remains active even once the Epstein-Barr virus has gone away. And I'd encourage you to listen to our podcast about the role of Epstein-Barr virus in multiple sclerosis with Dr. Lawrence Steinman, and one of my colleagues here in the Division of MS and Neuroimmunology. We also know that smoking is a risk factor in multiple sclerosis, both the risk of developing it in the first place, the risk of it progressing once you've already have the diagnosis, and accelerating the rate of progression in MS as well. And one of the things I found that resonates with my patients is if I can attribute their smoking to a particular amount of risk. And so this is a nice study by a Danish group who looked at almost 1,200 relapsing remitting MS patients and found that for each pack per day that someone is smoking, the risk of an MS relapse goes up about 25%. And if you think about the fact that our older MS drugs, the interferon therapies, the self-injecting therapies that are often used first line for MS, they only reduce the risk of MS attacks by about 1/3. So smoking is almost negating the effects of taking this type of MS therapy. And I think using those kind of comparisons can really help people understand, the very negative impact that smoking has on multiple sclerosis. And the last thing I want to talk about is the gut microbiome. Now, the gut microbiota is a really hot topic in the MS disease literature right now. And what the microbiota refers to is really the entirety of organisms that are residing in the gastrointestinal tract. And to put this into perspective, there are somewhere between 10 to 100 trillion organisms in our overall microbiota. And of those, about 70 to 80% actually reside in the gut. Now, the gastrointestinal tract also houses the gut-associated lymphoid tissue, which is actually the largest organ in the immune system. And the gut serves as the reservoir for about 80% of our immune cells. So that very close physical approximation to the microbiome organisms and most of our lymph tissue and lymphoid cells, we think that's an ideal environment for the gut microbiome to then influence the maturation and the development of our immune system. Now, our colleagues in gastroenterology who study inflammatory bowel diseases like Crohn's disease and ulcerative colitis have really blazed the trail in terms of thinking about this relationship. But we've come to identify it as an important piece in multiple sclerosis in recent years as well. So how might this relationship work in humans and the risk of developing autoimmune disease? Well, in this diagram, the composition of gut bacteria is depicted here on the top, with immune cells in the lymphoid tissue depicted here below. And in a healthy human microbiome, in A, we see there's an optimal balance or proportion of pro-inflammatory gut bacteria, which are these brown bacteria, balanced with these anti-inflammatory bacteria, which are in green. And so they provide signals to the developing immune signal system and results in a balance of T regulatory cells, which are anti-inflammatory, and Th17, which are pro-inflammatory immune cells. And so in this case of the balanced gut microbiome, we get a balance of these immune cells and we have a healthy immune system. However, if this balance of organisms is altered, something called dysbiosis, human disease can occur. And there's two ways that this can occur. One is if you've got too many of the pro-inflammatory bacteria that tips the scales to produce more of these pro-inflammatory Th17 cells, and you develop autoimmune disease. Or maybe you don't have enough of the anti-inflammatory bacteria, so you don't make enough of the anti-inflammatory regulatory cells, and again, the scales are tipped towards developing disease. So this is conceptual. So to prove that this is happening in multiple sclerosis, we've got to first prove that there's a difference in the proportion of bacteria in people with MS and people who don't have MS. And one of the first studies to do that in humans was by Sergio Baronzini, who took stool samples from healthy people and people with MS. And what he was able to demonstrate was that people with MS have an overabundance of these two species of bacteria, which are known to inhibit anti-inflammatory immune cells and to increase pro-inflammatory immune cells. He also showed that people with MS don't have enough of this other species, which is a gut bacteria shown to increase anti-inflammatory T regulatory cells. And subsequent human studies have implicated other key players, for example, Prevotella. And we've subsequently gone on to show that in people who have active relapsing remitting MS, who have evidence of disease activity, meaning they're having new relapses, they're having new MRI activity, they have less Prevotella in their gut, depicted here in red, versus people who have well-controlled MS with no evidence of disease activity have much higher proportions of Prevotella, implicating that species' kind of protective role. An altered gut microbiome isn't the only change we see in people with multiple sclerosis. There's also alterations in the intestinal barrier, or that physical functional zone of interaction between the gut microbiome itself and the immune cells. And for example, these tight junctions, which are the barrier that regulates what molecules kind of squeeze between those cells, are more permissive in people with MS. So you get increased intestinal permeability. And we call this the leaky gut syndrome, which is seen in about 70% of people with MS. And this is hypothesized to allow the bacteria or the byproducts of the bacteria to get out of the gut and affect the development and maturation of immune cells. And once they're out and into the blood and circulating, those microbes and their products can then alter that peripheral immune response and then migrate into the central nervous system to contribute to inflammation. And much like the leaky gut in MS, one of the hallmarks of people with MS is also a leaky blood-brain barrier, which then may allow more of these kind of microbes and microbe-derived metabolites and activated pro-inflammatory immune cells to enter the brain and spinal cord and promote more demyelination and more axonal loss. But the pathway between the gut and the immune system is called the gut-brain axis, and it's bidirectional, meaning that not only can the gut microbiome influence inflammation in the brain, but once that brain is injured, it can also send signals back to the gut via what's called the enteric nervous system to trigger more intestinal inflammation, more permeability, resulting in even an ongoing worsening cycle of CNS inflammation. So how do we break this cycle of dysbiosis, inflammatory immune cell activation, and demyelination? Well, altering the gut microbiome through things like diet, antibiotics, probiotics, even fecal transplants are all an area of active research. And in a mouse model of MS, we can actually give mice who have something called EAE, which is a mouse-induced type of MS. We can give them bacteria, anti-inflammatory gut bacteria like Bacteroides fragilis, or one of its products called polysaccharide A, or PSA. And if we give mice PSA and then try to induce MS in them, they remain very well protected against developing MS, versus the ones that didn't give the PSA are much more likely to develop MS. And the severity of their disease is also lessened if you give them this PSA, or you give them this anti-inflammatory gut bacteria. And we've seen similar studies in humans. And one of the first attempts to restore that balance was to give a probiotic called propionate. And propionate is a fatty acid byproduct of some gut bacteria. And if you supplement people with propionate, their blood levels of anti-inflammatory cells go up and pro-inflammatory cells go down. And if you follow them for a period of time, you actually see that after supplementation, their mean relapses per year go down. This is a significant difference between the two. And their rate of disease disability, their disability progression, also goes down. And so we haven't yet identified a definitive disease-modifying MS diet or formulated a probiotic that may help all stages or all subtypes of MS, or really figured out, does things like fecal transplants work to change that gut composition? I think these early studies on, looking at restoring gut homeostasis is really, foretelling great promise as a real new therapeutic approach to this disease. So I think we'll leave it at that today for this first lecture. I just wanted to recap that MS is an autoimmune disease that only affects the central nervous system. It's a global disease that can affect all ethnic groups, but the risk varies greatly based on some of the things that we talked about. And MS likely develops in someone who has some sort of genetic susceptibility, experiencing a sufficient set of environmental factors at critical time points in their life, probably during adolescence. The nice thing is that some of these risk factors continue to be modifiable even after MS onset. So there's a lot that you can still do as a clinical practitioner in terms of helping people, improve their diet, their vitamin D supplementation, not smoking, helping control some of these risk factors that we can still change to reduce disease activity in people that have already developed the disease. So that concludes our first lecture on MS. I hope you'll join us next time when we'll be exploring the clinical presentation and diagnosis of MS using some clinical vignettes. Thanks for your attention today.